That way they can come by and just check your badge and deliver your food. There's a couple of seats here and over here.
You can walk on through, yeah.
Four right here. A little bit of business before we get started. Cell phones, if you guys could turn them off or turn them to vibrate, that would be great. You have to leave in the middle. It's going to just mess me up, so do it nice and quietly so it doesn't before you leave, in the back of the room, you have your CE certificate, so anybody can use CE. You can get your certificate back there. We'll also have back there copies of the videos.
On that table over here.
Okay.
I think so. I put his
soft tissue lasers.
Some people don't have an iPad on it.
everybody who
They will drop that off
is
to your
in here
office.
has their name tag with them. So
We also have them on YouTube. So you can go to our YouTube page.
Can't find someone else.
Well, chicken cells, I don't know
Our
where
next
some of the
class
people.
is HR for the dental professional. It's a doctors only class, and it's in Cabianca in November. There's flyers in the back. It's going to be really great with a local company who does HR for all sorts of different businesses. They do medical and dental HR. And so that's really great for your doctors to make sure your staff is all covered and you're all covered. It's a really great presentation. On the table in front of you, you have a survey. I know, nobody likes to fill out surveys, I did it myself. But please fill them out. Please tell me if there's something you want to know about next year, whether it's orthodontics related or not. Because the more we get feedback from you guys, I can tailor the classes to what you want to hear about. So if there's something new that you want to learn about, just let me know. Also have a save the date card here for you too. This is for our holiday party. We have it every year. It's huge. Last year we had a cocktail party, and that seemed to go over. And then lastly, before you leave, we do have favors. And you're going to want to pick up your favors because it's going to help you with your party. Alright? So before you leave, pick up your favors. You'll see. And that's about it. Thank you so much for coming and agreeing to listen to me for the next 45 minutes or so. I talk a lot, and sometimes too fast. So if something happens and you need to hear more information, please stop me, raise your hand. I will answer questions throughout the discussion as well as during the end. I'm not a professional speaker. I'm a really great orthodontist, but I like shade, and you can laugh at the video afterwards. Last but not least, I'd like to introduce the people who actually make this happen. Kate is our PRC. She's in charge of setting up all of these lunch and learns as well as the drop-offs and the drop-offs to our classes. So Kate is in the back manning the camera. We also have Trish. She's my treatment coordinator. She's the one that all of your receptionists and the dental hygienists get to talk to when she's going back and forth. We have Audrey, who is our receptionist. She's Audrey Moore, who's on maternity leave, who, by the way, had her baby on Monday. She was 4 weeks early. We also have Annabelle, our sterilization tech, and Anna, my assistant, in the back as well. So now you know everybody. Let's get started. Okay, so we're going to start off. This is me, and this is our Project Stunning Smile contestants from last year. We did a photo shoot where we took our patients, and every dentistry. They don't have teeth up here. So you're probably not diagnosed correctly. So next slide. Alright, so the goals of today is to kind of go through with you guys what happens at our new patient exams. And then we're going to go over orthodontic diagnosis. What goes into diagnosing a case so that we can determine what are their best options. Should they be in a self-ligating brace? Should they be in a conventional brace? I hear those. We're also going to go over auxiliaries like appliances. All you hygienists out there screaming, yell at me because they have these crazy things in their mouths and know what they're doing. They don't know how to keep them clean. We'll also go over temporary anchorage devices and what they're used for and how they're used. Okay? Alright. So, new patient exam. When we have a new patient contact our office, they will be transferred to Trish, our treatment coordinator. Trish walks them through a series of questions, where they came from, who their dentist is. Once we have all the information and set up an appointment, contact the dentist. Show up. That's why you receptionist and front desk people will hear from Trish a lot, because what she's doing is she's calling you to find out, have they been in recently? Are their teeth clean? What's the caries list like? She'll
Looks
find
like
out
we have a full house.
cleaning,
Oh.
perio charting, if they need scaling cleaning, recent hand, and then she also contacts the insurance company to make sure that we have the correct insurance benefits for them. We do use the payments benefits in our office. It's not like they get reimbursed from their insurance company. We take care of all the paperwork for them, just like most of you guys do. A lot of orthodontic practices don't do that. So that's one more thing that we do. We also, when the patient comes in for the appointment, we review their medical and dental history. We found that in 2009 there was a study that went over diabetes and oral hygiene. You dentists might be aware of this, but it was kind of surprising to me that a patient with diabetes and oral hygiene has a 15% better chance or 15% lower cost in their medical costs, just like regular hygiene. Somebody who has chronic diabetes has a 60% chance of reducing their medical costs by just having optimum oral hygiene. That's huge. So we go over that medical and dental history. We give them a tour of the office so they can see what it's like, and they'll usually get introduced to it. We then take photographs. We use those photographs, we write all the things, show them things that are going on. We'll also take a panoramic radiograph if they don't already have one. And then Trish will go over prices. Patients now are savvy. They've shopped around, they've heard about braces, they've heard about these different types of braces. And Trish will go over the differences in the braces. The next slide. This is typically what we see when we take photographs. We'll take their full facial pictures. This is to determine their skeletal condition, as well as we'll take a panoramic and a supplemental x-ray to determine what's going on with their skeleton or their bone. Then we take a pictures of their teeth so we can determine what's going on with their teeth. Next slide. And then they get to see me. So they get about maybe 20 to 30 minutes with me. We do a full head and neck exam, intraoral exam. We review the photographs and the panorex with the patient so that they're aware of all the things that is wrong, that's wrong, that we need to fix. We'll also go over some treatment options. There's usually 2 to 3 different treatment options and treatment modalities with pros and cons of that appointment. They'll also go over financials and payment options. And then if they choose, we can go ahead and get started by taking additional diagnostic records, which are models, PA stuff, regular stuff, charting if we don't have any periodontal charting, and then referrals to the dentist for, if they get baby teeth out or things like that, or for a 3D CAT scan. Last thing we do is we do an oral hygiene review at that point. If somebody comes in with black on their teeth, the last thing I want to do is to brace them, because it's just going to get worse. So we go through a couple of appointments before we get braces on there, and we review their hygiene. There's a couple of things that you guys, if you've been to the oral hygiene and orthodontics, we went over some of the products that we use in our office to improve oral hygiene. Opal seal that goes over the entire surface of the tooth, so we can make sure that we reduce the white spots. We also have those little blue lights that we gave out to the dentist so you can check and see if your patient has that still on their teeth and is So if they're using a regular standard toothbrush, that they're doing it properly, the right amount of time. And also, if they need a mechanical toothbrush, we have that available for them as well. Next slide, please. So after we do all that, right, we're going to go over the different treatment options. So are they going to need a pipe here, or are they going to need some other kind of fixed appliance inside their mouth, like an expander or a curb appliance? Are they going to need to have something removable, like a short appliance? You probably are like, what are these things? We'll go over that in a minute. Then we go over different types of braces. A conventional brace that has the ligature ties around them, or a self-ligating brace that has a little door that opens and closes. We can talk to them about doing sure smile or lingual braces. And then of course there's a removable option. And in removables, most people think of Invisalign. Of course there's Invisalign, Invisalign Teen. There's also other products called Clear Correct. There's Red, White, and Blue and Simplified. And we're going to go over that with you today specifically because I get lots of questions about these two options because they're really great and they're really inexpensive. So we like those. Our patients really like those. So treatment planning. A lot of orthodontists click on their computers or treatment coordinators, click it out, and you get a treatment plan that's been produced by the computer. Or you can have a customized treatment plan. Most of my treatment plans are customized. You'll see spelling mistakes in them because I don't know, not that good at spelling. My customized treatment plan includes soft tissue, skeletal, and dental diagnosis. I look at the lip profile, the incisor position, and the dentition to determine how we're going to treat them. We also look at airway, temporary joint, or dental status, whether they have lots of missing teeth or lots of crown and bridge, their perio status, and any habits that people might have, whether it be a functional shift or a tongue habit. Next slide, please. At the end of the day, building smiles is like building bridges. New technology can improve your success, but you still need to have the knowledge, the planning, the materials and tools, the labor, the time, and client participation. If those aren't attended to, calamity will strike. The smiles will fail, just like a bridge will. Okay? Really, really important. People keep pushing technology. Knowledge and planning and making sure that you have time and client participation. Next slide, please. Alright, so orthodontic terminology. We talk about skeletal, dental, and soft tissue in the way in 3D. So we talk about sagittal or AP direction. So when you hear about a patient that has a class 1 bite, class 2 skeletal position, what we're talking about is front to back in this direction here. So dentally we're talking about overjet, protrusion of the teeth. We're also talking about molar position, so angle, class 1, class 2, class 3. That's all dentally based. A lot of people will use it skeletally as well because it's just easy. But it's really meant to be a more dental situation. So class 1 bite, the upper molar is just in behind the lower molar. Class 2, the upper teeth are further forward than the lower. Class 2 did 2, we kind of do this little thing. This is class 2 did 2, meaning their lateral incisors are kind of tipped out and their central incisors are tipped back. And then class 3 is the typical endobite. When we talk about dental, we're talking about these angle classifications. When we're talking skeletal, we're talking about the position of the bone in relationship to the skull. Okay? Because sometimes the whole upper jaw can be set far forward, or set too far back. The goal for our sagittal dimension is to either affect mandibular growth or dental compensation so that we can correct for a class 2 or class 3 malocclusion. Next slide, please. We also look at the teeth that face in the vertically, so up and down. So we're looking at, you'll hear about overbite or open bite. We'll also talk about specific teeth that maybe have extruded. You can see here that the levels of the gum line is significantly different on those two because what's happened is it came in inside of all the other teeth and dropped down. So you look at this and you go, oh, it's just really easy, Dr. Lynskey, just stick a brace on that and move it forward. The biggest problem is where you stick in the brace is right up against the gum line. When you put that brace on there, every time the patient chews, they have a chance of knocking it off. And then how do you move that facial thirds here. And you can see this patient is what we call a double facial patient. Very class 2. The chin is very retrographic. We've got this neck. They're looking straight at the horizon. And their jaw, instead of growing forward, has grown down. We've got this super long face. So anything that we do to correct for this, how are we going to do it? How are we going to fix the facial proportions? When we look at this little guy here, he's got a very square jaw. When you look at this and you go, oh, what's the big deal? What's the big deal? A lot of these patients can only be corrected with surgery in order to get their facial proportions lined up. And these patients are super hard to correct because they have these really strong jaw muscles. And every time you try to move a tooth, it's just cut down on everything and crack it all up. So again, this is our vertical skeletal condition. Next slide, please. Now, a lot of the pediatric dentists get to see a lot of this, transverse dental issues. So we have typical one-tooth crossbite. We might have some little skeletal inferior posterior crossbite where the upper teeth are biting inside of the lower. We have a situation like this where we have a lateral shift. So the midline of the lower teeth is significantly off the upper teeth. Part of that is every time this patient bites, he hits here first, and it doesn't feel good, so he moves his jaw over to the side. Over time, that becomes habitual. He doesn't know if he's doing it, he's just doing it. When you look at the jaw actually goes off to the side. Next slide, please. And this is what you get. So long term, when you have a lateral shift or crossbite in the back that's causing this shifting off to the side, the mandible will grow more on one side everything should line up nice and straight and perfect. That's why they call it a straight wire edgewise appliance. It's supposed to fill this slot here. They can be in metal or clear. A lot of clear braces used to have a metal slot inside them. Now they're getting really good where you don't absolutely have to have that metal slot. And then it does require a ligature to tie it in. It doesn't have a little door or anything on it. So you either need to have steel ligatures or these other ones, what have you. Recently, and it's really not that recent, when I was in school we started using Damon, we used speed braces. They're called self-ligating or frictionless braces. Okay? They have a slot. They have a door. This door does not require you to have to use a ligature. The door closes around the wire. The big difference is that this Damon, or well, there's a Damon brace, which is called passive self-ligation. There's, and I think speed is also passive self-ligation. And then there's Lotus, Innovation. There's a million and one smart clips. There's a million and one active self-ligation. Big difference between passive and active self-ligation is that passive never has a wire that fills this slot. It'll never fill it. It will never express the entire amount of torque that you need to using a passive self-ligating bracket. An active self-ligating bracket has a door that has a little elastic kind of spring to it, usually made of like NiTi or some kind of nickel titanium alloy, and it pushes the wire into the back slot. So Lotus, Innovation, Smart Clip, all these different types of other self-ligating braces actively push that wire to express the torque. Those active ones are also similar and have the same 222 or 118 slot size. So it's totally different than the Damon or the Speed brace that has a bigger slot size. Now what makes the big difference, okay, is that when you start aligning teeth and you put a round wire in this, those wires move around, and boy, those teeth move like this. And as we gradually move from smaller wires to bigger wires, the teeth start to settle into their position. When we get to finishing, using a passive self-ligating brace takes forever because you never can fill the slot. You see all these little tweaky bends. The hygienists will see these patients come in with wires with all these little things in them. It also expresses the amount of torque that would help passive self-ligating brace. The active one, you still might have to do some detailing there. It's never going to be as much as you have to do with a passive self-ligating brace. Now it sounds like I'm poo-pooing passive, but I don't poo-poo it. I use it all the time in my practice. But I do make sure that I'm choosing on the right patients. If I have a patient that's had lots of wear on their teeth, it's going to be super hard for me to detail them. So more patients can sometimes be more challenging at the end of treatment. So what does this mean time-wise? Well, if I used a conventional brace or an active self-ligating brace, and I use a passive one, they're both going to finish around about the same time. But their alignment initially is going to be much faster with the passive self-ligating brace. So now, kind of gone back and forth on some of these things. Our next slide, we'll go over some of the claims. I like to call this fact versus friction. The truth about self-ligating braces. So basically, for a long time, there wasn't any science or case reports. There was a big marketing push by Ormco, which is the makers of the Damon technology. And about 5 or 6 years ago, they pushed people into these Damon brackets. They are going to cure cancer. But they had no science. They had case reports by one doctor that had been using these braces for a while. They had anecdotal evidence. We also like to do, when we do any kind of studies, you want to look for, there's in vitro studies, there's in-house or sponsored studies, sponsored by the company who's producing the product. There's retrospective case studies. Randomized clinical trials and prospective clinical trials are the gold standard. So when we go and do research, we want to use these type of clinical trials to determine, really, are they doing what they're saying they're doing, or is it just like 2 or 3 patients in a special town that can get the results? So these are all of the listing of the different 2008 on roof absorption, another one in 2009 about plaque control, periodontal review, and then these two are the big ones. These are the systemic review. This is looking at every little thing that we can look at. Treatment time, overall chair time, detailing, all that. So the information I'm going to give on the next couple of slides is from these two studies. Next slide. So, back versus friction. Self-ligating braces come out with the same marketing plan, and it is marketing. Faster alignment, faster overall treatment time, faster appointments, less frequent appointments, more hygienic because there's no need for ligature ties. You'll never need a headgear because they don't make headgear tubes on the braces. It's better comfort for the patient, no extractions, better bone, less periodontal problems, and no expanders are required because their braces grow bone. Okay. Next slide, please. Braces don't grow bone. That would be great. The periodontists would be all over us if braces grew bone. A lot of the self-ligating technology is based on nickel titanium initial arch wires. These are all the different forms for the arches. The most, like an orthodontic practice doesn't want to have like 17 different types of arch wire forms because it's really hard to manage the stock. So we usually pick one. I think we have at least two that I know of from, we have this form here, and we also have the Europa form. Some of our Damon wires are this Europa 2 form. And what you can see here is this Damon wire is super expanded, okay, versus some of these more narrower ones. This becomes an issue because when you're using a wire like this, it expands your intercanine distance. Number one thing that you'll find when you look at a retention study, the number one area that you're going to have issues is intercanine distance. That is where we're going to have relapse. If you expand the intercanine distance, you will lose that expansion. It will relapse. Unless you use a bonded retainer. So a lot of the Damon practices, a lot of Damon do bonded retainers on the top and the bottom, Damon positioners, or bonded retainers with a positioner on the top of it. Okay? Part of that is because they are, I mean, there's nothing wrong with it. If they're expanding it and they can maintain it, great. But if the patient refuses to have that type of retainer, can't keep their hygiene clean, and that retainer comes off, they are married to their retainer. Otherwise, they will have relapse. And this is really, really important in the lower arch because as we age, those teeth will shift and move. And so if we are expanding that intercanine distance at all, we will have relapse. No doubt about it. Next slide, please. All right, so the research. Those two studies I alluded to before, they do state that we have faster initial alignment in moderate to severe crowding cases, which means when we're using a self-ligating brace, the braces go on. Within 6 months, those teeth are going to look super nice and straight. Patients are really happy. They love you. They think you're the best. When am I going to do my braces on? You said it was going to be 2 years. We're straight now. There is no difference in overall treatment time, okay, between a conventional brace and a self-ligating brace. The appointments are, however, 1 minute faster. So if you're, building your schedule on a 19-minute adjustment versus a 20-minute adjustment, then that's going to be helpful. Appointments for initial alignment can be done as far out as 10 to 12 weeks versus 6 to 8 weeks with a conventional brace. The reason we do a smaller time period with conventional braces is for oral hygiene, because again, they're having ligatures on there, so we want to make sure they're keeping it clean. And for the initial alignment, because initially we want to change the wires so those teeth move faster. They also found, the research found, that they do have reduced plaque on the teeth, and that's huge. I mean, as an orthodontist, I don't want to see plaque on the teeth, and knowing that the difference between a self-ligating brace and a conventional brace is statistically significant for this is huge for making that decision. There is no evidence on this bone growth theory. The fact that they'll never have to extract a tooth, that's false. That'll not a diagnosis of treatment. There's no difference in periodontal measures. There's a higher incidence of self-ligating brackets debonding. We don't know why that is. I have no idea. But layperson, a dental professional, was less acceptable for a self-ligating brace than a conventional brace. I don't know if I can put a lot into that, but it's in there. They have a longer finishing process, which one right behind Dr. Lynskey, with a passive self-ligating brace. Retention requires longer retainers, and then physicians are also recommended for these patients too. All right, next slide. Bottom line is the real big differences, and the things that go through my mind when determining what kind of braces I want to use on the patient, is they have faster initial alignment. So someone who's got really, really, really crowded teeth and they're anxious to get started and get going, they definitely want to use a self-ligating brace on. They're going to be happier, they're going to see results, they're going to be enthusiastic about it. Secondly, is better oral hygiene. So if a patient that's at risk, that would be ideal to get them into a self-ligating brace. Okay, so anybody have questions about, yes?
I just have one about the bone growth. I'm assuming they're speaking about the bone.
Yes.
Now, so I've seen phase 1 treatment used with payment where it's being used as expansion, like expansion transfers. The palatal suture has been closed. So in that case, they take into account the bone growth there.
Well, there was a couple of research studies that looked at expansion, because that's part of the Damon philosophy actually, is we can make these big giant wide smiles because we have this biodimensional growth theory, and that you never have to use an expander. Expanders are sutural expansions, so they're taking these bones and spreading them apart so that we can get structurally skeletal. By using a not using an expander, you can get the width by making really wide arch wires, and by using rubber bands that the patient can add onto it too, and then some springs and things to get that expansion. Unfortunately, it's not sutural, so it tends to be like tipping out of those teeth. If you have a lot of torque already built into the brace, you can possibly get root movement, but they've never done, and this is the thing, we've been doing these studies forever. Not once this has been asked from the get-go. Has there been any research or cone beam research to determine if bone is grown?
Are you sure?
In fact, there was a study that was getting ready to be published, and the gentleman who created the study and did cone beams on it has just been hired by Normco, and so now that study is not coming out. I don't know. I can't tell you an answer to that. I've tried to do expansion on phase 1s with brackets only, and they debond, and the kids don't wear their rubber bands, and I just want to make it easy for them. And I just don't think it's easy to use the arch wire expansion on a child, a little child. It's just, for me, in my hands, that's what I found. So I use the expander. It's in and out, and they get to go on with their life. So that's what I feel. Any other questions? Yes. There's no difference in root absorption between conventional braces or self-ligating braces. Does anybody want to know about root absorption or how we determine it and things like that? No. Root absorption happens at the very tips of the roots get resorbed away. It happens in every single orthodontic patient. The average is about 1/10 of a millimeter. And part of that is just where the cells are at the very root tip. They can take that root tip and make it shorter. Our big issues is when we start seeing 1/2 millimeter or a millimeter. I had that happen to me, and it scares the devil out of you, and then you want to like contract them. It is scary. There are some indicators that we can use that will help us determine whether or not a patient is susceptible to root resorption. It's shapes of their root tips, it's time in treatment, but overall, they did these studies. Not one of them showed that there was any difference between root resorption between conventional braces and self-ligating braces. There's also no difference with Invisalign either, so if you have questions about that. Yes?
It all has to do with the thickness of the wire, right? Instead of using heavy forces, using light forces.
Yeah, using a lighter force that works over time. I don't know flexible. In fact, that's part of Trish's, when she goes to the new patient exam, she shows them how these wires work so they understand. Because when they're in these very light, flexible wires initially, there's a really good chance that they'll debond the bracket, and that thing will flip out. Or that the wire will flex out of the brakes too. So we like to go over that with them so that they can see what it's like. And it's kind of cool. Any other questions about back versus friction? Does everybody understand the concept of why you would want to use a self-ligating brace? Just moves the teeth a little bit faster. I have a tray full of braces back, all different types of braces, so you can kind of see them. We also have the braces on a wire, so you can see them slide back and forth, the difference between a self-ligating brace and then a conventional brace that won't slide as easily on the wire. So if anybody has any questions, Trish has got them all back there. Okay, next slide, please. All right, so we've got fixed braces. We can do self-ligating, or we can do conventional. You can also do something called Sure Smile. There's only 3 Sure Smile dentists in the Bay Area. It's basically what happens is we take a scan of the oral cavity, we send it off to a company. It's very similar to Invisalign, where they'll make a computerized image of the teeth, and then they build customized braces and or arch wires for the patient. They send you this kit, and then you put the braces on, and then you put one wire in, a second wire, a third wire. It's awesome if everybody keeps their braces on their teeth. And the customized arch wires get put in correctly. And nobody breaks the bracket. It's really great. It is very precise. The biggest drawback is this. It's about $800 for a case. That doesn't include the cost of your braces and your wires. And you also have to buy this scanner to scan them out. I went to school for a long time, but I like to think that I can put the braces on pretty close to ideal. I don't really want to tack on an extra $800 to my patient for that. For me, not getting the bracket placement or as close to ideal as I can. But I'm not, maybe I'm using loops now, so next slide, please. So,
Did you want to get your feet in a thing to go, or would you like to maybe have a seat there and eat? I don't know. If you're hungry.
Yeah, I'd like to do that.
Okay. Okay, I'll get them.
Make this mold, and then you put them in the mouth.
I have to go through my charts.
No problem. Thanks for coming.
Thank you. That was great.
You're welcome.
Thank you very much. I have.
Okay. Okay. Have a good afternoon.
We also have legal braces. I think Katie Bales is the only one doing legal braces. I don't do them. The patients get their tongue gets chewed up. They can't talk properly. Accumulation is really hard to floss behind me, so I just don't do it. If they don't want to have regular braces or Invisalign, I send them to Katie. Next slide. Come down to Invisalign. Almost everybody here is familiar with Invisalign. Yes. Invisalign is great. It's super expensive for most practices. It's for mild to moderate to severe class 1 cases. We can do extractions with them. We can do class 2 and class 3 cases and attempt to get class 2, class 3 correction. But the maximum we found we can do is about 2.5 to 3 millimeters. So if they're more than class 2 or class 3, then they will not be able to they won't be able to get that correction. Invisalign Teen, is everybody aware of Invisalign Teen? It's the exact same product as Invisalign, except it has compliance indicators on the back of the aligners, so that we can make sure that they're wearing them the appropriate amount of time. And also, it costs more money because there's built-in insurance that if they lose an aligner, they can get it replaced. Up to 6 aligners. We tell them 4. But it is up to 6. And then there's also, I really like the Invisalign Teen product. It works really well. It has eruption tabs for teeth that are still growing in. Really is great for phase 2 patients, especially if the phase 1 was traumatic and they didn't keep their teeth clean and they just don't want to do it again. It's really great. They can keep their teeth nice and clean. As teenagers, they can get all the food they want to get into their bodies and they need to get into their bodies without diet modifications. But it is more expensive than traditional braces because of the lab cost. Most of you guys are doing Invisalign would know that the lab cost is anywhere between about $1,400 and $1,800 for Invisalign. So that's just your lab cost. That isn't anything else. There's also Clear Correct, very similar to Invisalign. However, it's very technique sensitive for the practitioner. It takes a lot more time for me because I have to adjust the aligners every time they come in. I'm not a fan of it. It is less expensive. It's about $800 for a so, and they just don't have research on it yet, so I'm not keen on the Clear Correct just yet. Next slide. The next option we have is something called Red, White, and Blue or Simplify. Some of you guys may have gotten some letters from me about these. Red, white, and blue is 3 aligners. Red, white, and blue. They're not colored red, white, and blue, but they Invisalign patented numbering and alignment. So there's 3 aligners. Simplify is 5 aligners. And so this is what we're doing here. So somebody has relapse and they just have rotations on their 4 front teeth. Alright, the anteriors only or spacing. This is the way to go. It is about a third of the cost of Invisalign. We do get refinement. We can still also use attachments. So this is a really great option for mild to moderate crowding. I don't think I'm going to get through everything. It's very ambitious. Next slide. Extraoral appliances. This extraoral means outside of the mouth. So we have headgears. This is a protraction headgear. It's for class 3 patients from doing the upper jaw forward. Elastics go into an expander that's in here. We also have the cervical headgear, which is for one of those brachyfacial patients, like a square jaw patient. And then we have a high full headgear, which is for a more vertical patient. We still use these because people still have growth problems. So we still have to use them. Next slide, please. How is everybody doing on time? What time do you all have to get back to work? 2, 1:30, 2? Okay.